So thank you all for your presentations and for joining. So I wanted to start us by asking if you had any reactions to the earlier patient panel and even to Pete Early's presentation, just to start us off.
I mean, beyond, they were all fabulous, but I think they grounded us in really important things, right? I think Pete's panel, or Pete's discussion, talked about the reality that families face and how our system, quote unquote, fails so many. Mm-hmm. And, I think just knowing people in my own family who've had similar experiences, somebody in my family a couple years ago attempted suicide. And I worked in mental health for 25 years, and I never felt so powerless in my whole life trying to communicate with that facility, coordinate that person's discharge and follow-up care. And I felt like I'm somebody who kind of knows something, mm-hmm. and I still felt totally powerless. What do other people go through every day?
Yeah, I mean, I was, I guess, embarrassed for my field. I always am. I don't know who these psychiatrists are or how they're getting trained. Something is really fundamentally wrong. And I think that I was telling someone earlier last week, I was at James Madison University speaking to undergraduate health professional students, PA students, BSW students, and the like. And I was like, you guys are it, man. My hope is on you. So, because you're the generation that doesn't have to go down the path that's been laid out. You have a naturally innovative way of thinking. And I think that it's going to have to take something that we have not thought of yet in order to address this. We're not going to get enough providers. We have to find better ways of task shifting. You have BSWs that can't do things that a peer specialist can do because of turf wars with scope of practice with MSWs. Like, how does that make any sense? You have LPCs and LCSWs fighting over things that make no sense. So, I mean, this all goes, to me, speaks to the importance of leadership and all of us doing our part and not waiting for someone else to do something. We all have a responsibility to act. But I also think we have to nurture that creative part of our mind, because we just can't keep working with the pieces that we have, trying to put together in different ways. It's just not going to work. We have to really have something transformative that solves this issue.
I think from where I sit, the hardest part is everybody's well-meaning and trying to do a lot of good, and we're still falling short, and that's hard. That's hard. We all get into these professions to make a difference. So I'm giving more of a benefit of a doubt to all of our colleagues, right? I think one of the things we are doing now with our universities at Shady Grove is to do multidisciplinary practicum training. It's like 6 weeks in the summer, and we take about 16 to 20 students, and we run them through pharmacy and social work, and criminal justice, and nursing, and public health, counselors, social work, in an attempt, and then we have them experience the county in its various aspects. And so when they graduate or they come out, they've got sort of more of this interdisciplinary feel. I think we do ourselves a great injustice by staying in our silos and in our lane. Families are messy and issues are messy, and they need all of us to work together. But I also think it's wrong for a vulnerable person or a client, a consumer, whatever language you use, to carry a Rolodex full of nurses and social workers and therapists that they have to interact with. It's incumbent upon us to figure that out. That should not be their burden, and they should not have to tell their story over and over again. It's demeaning, and that's why we have technology that can make all of that possible. And so I think as professionals, there's a place where we can go as systems to make improvements.
Can I just say, what you also made me think about was regulatory relief, right? We have a system right now in some places in the country, if you come into care, it's a 40-page intake interview that you have to go through that could take several hours, and you have to tell very intimate things about yourself to somebody you've never met before. And I always wonder, to what end? Other than satisfying some requirement by a state, that's information that's not used in any way, meaningful way to inform care. So why are we making people do this?
Yeah, those are good questions. We've talked a little bit about this multi-sectoral partnerships when folks are in crisis and when they are in need of collaboration from those entities. But I wanted to ask about this notion of prevention and the work with multiple partners, different sectors. We've heard schools, I think, mentioned, WIC or TANF sites. Can you talk a little bit about the view of this sort of multi-sectoral prevention approach?
So I'll start. I think when you think of, we serve on an average about 97,000 to 100,000 households a year. On an average, our clients are using more than 2 services. And by that, I don't mean TANF and SNAP, right? I mean domestic violence and homelessness, mental health, early childhood, aging service, whatever. There are more than 2 services. And that tells us that any one issue, just responding to one presenting issue isn't going to get to a better, alleviating the presenting issues, right? So you have to collaborate. You have to build partnerships. Our general, we have an integrated practice model. We find that housing tends to often be the common denominator. And there are other issues always that destabilize the housing, but if you could address the housing, then you can start to make inroads into the other issues. Whether someone is re-entering the community from a prison system or whether they are in a shelter, can we prevent homelessness from occurring? And if not, then can we get them into housing quickly? Having said that, then you need to make sure that people have money for food. If they're worried about, it's Maslow's hierarchy, if they're worried about their basic human needs, they're not going to pay attention to getting well, whatever that well is. And now if you were to do the prevention argument, you'd say, let's respond to these issues early. If someone's coming for food stamps, let's ask them up front what are the needs do they have and wrap it around so that it isn't 3 months later that the caseworker hears that there's domestic violence, possible risk of homelessness, or there's depression in the family, right? Ask those questions up front. And so to the degree that we're building a good, so then we get into the prevention mode. What we aren't paying attention to is promotion, which is the education campaigns and the outreach and the many ways in which we've talked today about getting voices heard. And I think all of that, then you have to sequence it and thread it in a way that makes sense.
I'll just underline the point about accountability for outcomes. If we can agree on the ultimate outcome, that's really where you see merging of the multi-sectors. They're all driving towards healthy communities that are safe, where there is economic thriving, where people are part of communities and connected. These are the hallmarks of a healthy society. And oftentimes multi-sectoral efforts fail because people are responding to the outcomes that they're held accountable for. And there are all these barriers to collaboration that come about at the federal level, certainly that's the case, but even at the local level we see that. So I think who's going to hold elected people accountable to pushing towards these multi-sector approaches? It's hard work, but I have a degree of impatience around accepting it the way it is. I think that we need to stop accepting that it's hard. It is hard, but that doesn't mean that we can't find a way around it. If we can get people activated, motivated, and engaged in agreeing on the shared outcomes and moving in that direction together simultaneously. Because you have pockets of programs and the person at the top doesn't even know they have a program for that. All of that is where innovation and using information in a smarter way can help you to build efficiency. So some people are happy with efficiency, and you can do the right thing to give people what they need. So everyone can have their values really strengthened by that approach.
I think the other opportunity that all this kind of approach presents is to normalize mental health and substance use treatment. I'm thinking about one of our members in Denver, Colorado, that when they were conceptualizing building a new center to deal with children and families, that they brought in because multi-sectorial partners, but they also have a hydroponic farm. And they're able to offer low-cost food to that community, and to they working with housing provider to help bring housing. And when they first were presenting this idea, that first community didn't want this facility there, and now like other parts of Denver are saying, hey, will you build one of these in our neighborhood? And then also mental health and addiction treatment is available there, so they're also able to kind of meet people where they are. Respond to community needs, but also normalize treatment. So I think there's some other opportunities here.
So let me ask this question about meeting the needs of folks from diverse cultures and backgrounds as well. We heard a little bit about Montgomery County and the diversity of the population you're working with. How do you, as systems, as providers, think about meeting the needs of the diverse populations that you might be working with, and how do we improve that?
I think what gets measured gets treasured. I speak to a lot of provider groups. I always ask them, how many of you have heard of the national standards on culturally and linguistically appropriate services? And like a third of the room will raise their hand. Now, if you talk to administrators, they all know because they're checking some box off that they're doing it. But how is there this huge gap? Yeah. So I think that having, what is the measure that you're aiming for, having it be integrated, to me, it all fits together. Trauma-informed care, you can't do that unless it's culturally centered. Integrated care, no matter who you have at the door, if they're not engaging the person in a way that's positive, they're not going to engage the services. So I think that they're threads of the same quilt, and we need to also within ourselves stop being in our own silos, like I'm trauma-informed, okay, I'm integrated care, okay, I'm cultural care. It's all the same thing. So we need to start speaking together, translating within our group of behavioral health so that we can be that one voice speaking externally to the people that are in charge and have never seen a person with a psychotic illness in recovery. That they did, wow, there are a lot of people that are making very important decisions that are still at that level of, is recovery possible? Quite a number of people that I've interacted with, and I don't even get around that much. So it's scary.
Wow, that's really good.
I love Glenda's phrase, what gets measured is treasured. And I think one of the problems we have in behavioral health is we have way too many outcome measures that people are using, and there's no standardization. So from state to state, county to county, everyone is doing their own thing, and we can't tell any kind of story or have no picture about what's actually happening because of that. So I'm all for a parsimonious approach to standardized measurement across systems, states, so that we actually can improve care. But right now we have the Tower of Babel.
So in our county, we have we've got these entities called minority health initiatives and programs, and they are responsive to the Latino community, the Asian American, the African American, and the continental African and Middle Eastern communities. And it's the peer recovery and the health community health worker model that's going to get us there, right? Yeah. So people don't trust large systems to care for them. And as it is, there's such a stigma and taboo around some of these immigrant communities around mental health and what it's going to mean for them very personally in terms of their marriage. Could they stay in it? Will they get kicked out? Will they be defenseless? So many issues. And so it is really that community health worker model. I wish we would build it out more. Last year, 2 years ago, CMS actually said that Medicaid would pay for the community health worker model. But there's not standardization around, certification, what skills, what competencies, how do they get paid. So there's a ton of work that we could easily do, I think, to get us there. But we have to acknowledge that these communities don't trust easily, and they're not going to come out there and say, give me services. And so I think the bar is much higher there. There aren't enough bilingual therapists and social workers and psychiatrists, and whether it's in medical practice and or behavioral health practice. And so I think there's a lot of work to be done and significant mistrust.
Great, thank you. So I want to open it up for questions from the audience, if folks have any. See someone standing there. Go right ahead.
Hi, everybody. Debbie Plotnick, Mental Health America. Thank you. Couldn't agree more with everything that you've said, that what we're looking at is a system where even when folks have private insurance, they're kicked into the public systems. And you talked about, I really appreciate the infighting between the guilds, if you will. That's a real problem. And I'm noticing another issue that I'd like to hear you comment on, and that is even within the provider systems, and Chuck is right, there are many of them, we see the line items fighting with each other. For example, we see that we're not going to pay for a particular medication, a particular therapy, a particular kind of support, and this happens both in the public and the private systems, how we're siloed even within our silos. Comments?
It's true. I mean, I think that there's a big issue with attempts to contain costs, right? And so until we reconcile the value of inputs and what works for whom, when, in which quantity, and have standardized ways of answering that question, we'll continue to face, because of disparity in attention that mental health conditions are given compared to other health conditions of comparable magnitude, we're always having to push back against that disparity in attention. But we do know what works. So we do know that there is such a thing that as evidence-based practice that does improve outcomes. And I think we need a stronger support from innovators and early adopters, whether that's a state or insurer, whoever wants to be the lab. We have stuff that's coming out of CMS. But then after that, after you've demonstrated, you can't just keep doing that. You have to find a way to get the early majority, and that's now our usual care. And there's a lot of places within models of care where we have over 100 studies of what works, but somehow the regulatory environment doesn't promote that or require that as the standard of care, and I think we really have to fix that.
Thank you.
Oh, no.
Next question.
Hi, I'm Susanna Gopalan from Congressional Research Service. It's a question for Chuck. The Certified Community Behavioral Health Clinic demonstration, such an interesting collaboration between CMS and SAMHSA that's occurred, and if I understand correctly, it's just a few months since the demo went live. So I was curious, it seemed like a very compressed timeline, both for the states to figure out how to pay and certify these providers, and for the providers to deliver this wide scope of services. And I was wondering, what are some of the themes that have come out in the 8 states from these first few months? And does it, based on this little bit of experience, seem to you that this 2-year demo will produce perhaps a platform for wider system change in the way these services are covered in Medicaid?
And Susanna, I wish we were 8 months in, right? So most states actually didn't implement until June or July of this year. So we're actually much sooner in. And most of the clinics right now have just been hiring staff. There are some new requirements around being able to provide addiction treatment. So they've had to hire a lot of addiction treatment providers and rethink their systems about how to incorporate that. So I think right now we're still on the early side of that. There's a meeting today in Nashville of about 50 of these clinics getting together and talk. So maybe by the end of the week, I'll be able to answer your question more. And she played a huge role. She was our attorney working on the early days of fighting with CMS over some of the regs. So thank you.
Hi there. I was hoping you guys could comment on the possibility of and how we can prepare for population health. And the sort of specific problem was at a conference once, this guy stood up and said, like, okay, say I'm a primary care provider, I'm fully capitated, I have an attributed population, I'm being paid based on outcomes. What do I literally do when I get to work the next day? And I think it's sort of the problem we have where it's like we're all, and it's easy to run a specialty care, right? Because like people are presenting to you with a specific issue and you're sort of supposed to be managing the set of issues, but you just have like a blue sky population out in the world and you have the reimbursement and the flexibility to do what it is. How do we in the room prepare people to be successful in that endeavor?
Well, Nathaniel, I don't know if I have an answer for you, but I think the biggest problem is attribution, and I don't know that it's any simpler in specialty care than it is in primary care. Because if I think specifically about our members and Medicaid, and people have freedom of choice, it's not so simple that you have total responsibility. You can claim total responsibility for this person because they have a lot of freedom in where they seek care.
Yeah, but even, kind of lower hanging fruit in large health systems and hospitals that not everyone, you take things for granted, right? Not everyone's looking at racial and ethnic data within their hospital system to see, oh, how are these guys doing? So if you look at the whole population without looking at those nuances, you'll think you're doing fine, but you're not noticing the disparity within your population. And the eyes go to the numbers, the 10% of the population consuming 20 to 30% of the, it's like too late once you let it get that far. But if you intervene early, you can prevent that group, not that group right there, but the other group that's waiting to take their place. And I think those are the things we have to kind of balance, the big dream of what we'd like with the actual reality of the missed opportunities that really persist in our systems. I'm not taking that one.
I'm good. I'm good.
Hi, I'm Mark Dreskin. I'm a primary care physician in Southern California. You had mentioned something about what we could measure as what is favored. And doctors like me will basically encounter large meetings where we're urged to do more for patients with behavioral health problems, and we're told about depression. And it's so important with depression. It affects jobs and livelihood and the economy and so on. And they don't mention anxiety disorders. And it's strange for people at my level because it's almost one-to-one. We'll see people with a pure depressive disorder, a pure anxiety disorder. And so what I'm wondering is, do you, and it's even at the reimbursement level, that's what's so interesting, is that I worked on a couple of projects that related to how well the depressive disorders were reimbursed, and then the anxiety disorders almost not at all. So I'm just wondering if it's that with research and having this clear measuring stick of the PHQ-9 and being able to look at its effect on functionality and presenteeism and absenteeism, is that one particular reason that might be? Or is it that the anxiety disorders just have all those different types of anxiety disorders, but we tend to see depression as one thing? So I'm just, I wanted to ask about your perspective on that.
I'm sure, Chuck, you have something to say about this, but people don't have one thing. Come on, right? Anyone that actually sees patients, it's a rarity that you're only going to get one thing. And I personally struggle with this because of my background in looking at trauma work and PTSD and resilience. Like all the patients that are not recognizing PTSD, they've been picked up for depression. There's a lot of symptom overlap. So I struggled with this myself, but then I came around to say we're doing nothing. So can we start with depression as a starting point, not an end point? Because I think we have to have multi-diagnostic tools and resources in primary care. The list of things you have to screen for is more than any one provider has time for. So there's a lot of challenges with kind of thinking holistically about people and what might work well as like a population indicator. It's probably a good indicator of the overall quality of behavioral health care, how you're doing on that depression screening metric, that depression remission and response metric. So I think you just have to balance the trade-offs with what you measure, and hopefully new ways of measuring can make it easier because you can engage patients in self-assessment and just push the data to your provider. That would be way favorable, right?
I know, I completely understand what you're saying. What sometimes happens even down road though is we have those collaborative care programs within our primary care. If we teach them everything they need to know about depression, but we haven't given them the skills to help someone with anxiety disorder, and someone comes through the door and their mood is actually doing pretty well, we need to offer more. So we've gone down that road too. I completely understand what you're saying, and I do agree with that. But yeah, so was there another comment that you had?
Yeah.
Okay.
So do you have a brief question? I'm sorry, I was talking to the gentleman behind you. Just to be sure, we're getting ready for lunch, so I want to make sure that we don't stand too long between folks and food.
Well, that's why I'm here. It's lunchtime. No, I'm just kidding. I don't know. It's not really well, it's kind of a question and comment, but one of the things that At Fresno State University, Robert Wood Johnson Fellow, one of the things that I think it's important to recognize is that in many communities, and I'll speak for my community, Latino community, is we already have systems of behavioral health or mental health in place. The only issue is it's a disconnect from mainstream mental health care. And I think that's important because how do we utilize what's already existing, right? We often see, and I'll give you an example, is that going back to training, I think Glenda had mentioned that. I think that's a big problem is that we are training, for example, in social workers, in my case, these theoretical frameworks that are European and British, which that's not the problem. The problem is when you go out to the community and 80% are Latino and 20% are Hmong, 5% African American, it's really difficult. So how do we think outside the box and really begin to understand the role of culture, the manifestations of mental distress, and begin to create novel approaches to working with people of color? I think that's a huge step that we need to begin to look at.
Thank you.
So, in the county, though, we've identified something called our equity initiative, and it's exactly what Glenda was saying. When you look overall, Montgomery County is the healthiest county in the state of Maryland. When you go underneath it and you start unpacking the data, the outcomes for our minority populations, it's not as bad as the entire state, but it's worse than that for the majority population. And so we can either rest on our laurels or we can say, we're going to make efforts to close this disparity. Well, if we're going to try to close this disparity, it's wrong to assume that education stops when you get your degree, right? So what is the workplace training, capacity building around issues of identification of disparities, disparity reduction, working towards an equity frame? And if we as a department, we don't do budgeting decisions unless we ask what's the impact, right? And we have an equity tool we've built and we apply that to our budgeting process. And that's to say the entire system needs to respond. It's not enough that our workforce is responding, right? It's not fully aligned. And so the use of community health workers, the class standards, applying those to contracts. But then here's what we don't do. We apply the standards, but we don't resource the contracts. The contract value stayed the same for 10 years. But we're expecting everybody to offer language access and to do culturally competent services. Well, it's humanly impossible, and so it's not a fair expectation to put on our contractors. So we really have to think, and we struggle with this, right? Do we serve 100 people, or we say it's okay to serve 80 people because we want you to take that money for the 20 people and apply it towards, because there's no more money in the system. So we want you to apply it towards culturally competent care. And these are everyday decisions that we have to confront without any good, I don't have a good blueprint. I'm just telling you that these are the kinds of things that we have to think through as we're operating and implementing a system of care that is under-resourced and skewed. It's not, it's well-meaning, but it's not always responsive to the needs that are out there.
Thank you. Thank you for the question.